The consumer majority board that governs the health center, that means that 51% or more of the board that makes the decisions about the community health center and its operations, are actually patients from the community. So really making sure that the interests and needs of the community are represented in all aspects of the community health center. And they employ a pretty broad definition of health. So beyond that initial primary care visit that you need to get, health centers really focus on enabling services like transportation and translation, and think about kind of treating the whole patient and making sure that they can get a comprehensive set of services when they visit. So the typical health center not only provides medical care, but there are dental suites, behavioral health services, a variety of other things that help really make sure the patient is cared for. So as I said, in doing the survey on the clinical workforce needs, and we wanted to focus on clinical workforce because that in and of itself, we were told, is a huge issue for health centers right now, the actual workforce that's delivering care. We wanted to get a sense of what their current clinical vacancies were looking like, what their top priorities were staffing-wise, what their recruitment and retention challenges were and those experiences looked like, and then also what kind of participation they had in programs, federal programs specifically, that aim to help place and train clinicians in underserved areas. So community health centers being one of the top places for that to happen. So I'm going to go through the results. They fall into a few different buckets, and so I'm going to kind of do it that way, and just let me know if you have any questions along the way. So starting with vacancies, looking at the state of clinical vacancies at health centers right now, you'll see that tall bar with the arrow next to it shows that 95% of the health centers who responded to the survey, which was a representative sample, so we'd like to say they represent the health centers across the country for sure. 95% of them have at least one clinical vacancy right now. So summing that up, basically at any one time, a health center can expect to have at least one vacancy on their clinical staff, which is pretty striking. That next bar will show up again and again in the slide I'm about to show you, but 69% of health centers said that they had at least one vacancy for a family physician, so physicians that are usually the head of care teams. Other ones that a lot of health centers said they had vacancies for were nurse practitioners, medical assistants, and registered nurses. And then you'll see in that box, when we took a look at how many new patients health centers estimated they'd be able to bring in if their previously unfilled vacancies were filled, it came out across the country to 2 million more patients could be served by health centers across the country if their clinical vacancies were filled, which is a lot of patients. And so looking at what it was like to try and fill those vacancies, we asked health centers to rate the kind of level of difficulty that they experienced in filling their vacancies. And again, like I said, family physician really rises to the top. 66% of health centers said that a family physician vacancy was very difficult to fill, which was the most difficult ranking they could get. Internist and psychiatrist also rose to the top. And you'll see that that maps on pretty directly to the next slide, which talks about how long on average health centers said that they spend recruiting and trying to fill for those positions. So that first bar is a psychiatrist, and on average health centers are spending over a year, 12.7 months recruiting for a psychiatrist vacancy. For family physicians and internists, it was almost a year, just a little over 11 months, which is a very long time to not have such a pivotal member of the care team on your staff. And so this kind of shows a lot of what I just talked about. We asked health centers to rate, to basically indicate what their top priority vacancy would be to fill. If they had one chance to fill one of their current clinical vacancies right now without any of the normal barriers in place, who would you want to fill? 51% of the samples said family physician. So by and large, family physician came out way ahead of all the other ones that were listed. If you combine the different behavioral health categories together, that was the next most chosen one, but again, 10% is what you think of doing. So moving from where those vacancies are to what kinds of recruitment and retention practices and experiences health centers are having, we asked them to talk about how important certain barriers were to recruitment and retention. Recruitment is that blue bar, retention is the green. So right off the bat, you can see that they pretty much mirror each other in terms of what's really causing the most problems. Competitive salary, competitive benefits, and then community amenities and other just kind of location-related factors based on where the health center is located were the three most often chosen as very important, so the most important problems that they had for both recruitment and retention. And then we wanted to know where people are coming to the health center from, where health centers kind of recruiting people from. So we asked, who have you hired in the past 2 years? And we gave them a number of options. So 58% of the health centers said that they had hired someone who had trained at their health center, really kind of starting to show this trend that you'll see in a few of the other slides, that health centers are really the business of growing their own and trying to train clinicians that are going to end up staying in the communities they serve. The next most highest one, 30%, said a health professional who trained at another FQHC, so kind of indicating that there's this network of health centers that, mission-driven individuals who are getting trained in this really pretty unique care setting. 30% said they hired a veteran, which was exciting for us to see. And you can see former Health Corps, AmeriCorps, and VISTA volunteers, as well as Peace Corps volunteers. All of those had at least one health center say that they hired someone that fit that category. On the more negative side of things, we wanted to know where health centers were quote-unquote losing people to. So we asked how often are health center clinical staff leaving to go to a private primary care practice, a hospital, or another health center. And you'll see that private primary care practice and hospital were the two that most frequently as their choice. So that's definitely kind of helping highlight where health centers' main competition is in terms of keeping their clinical staff. But it was encouraging to see that 41% of people, 44% said they occasionally or frequently were losing someone, but they were going to another health center, which I think everyone who's in health centers is kind of a community and a movement, so that was encouraging to see that. I'll just talk a little bit about something that I think is going to get touched on in other discussions today, but we did want to take a look at federal programs such as the National Health Service Corps and kind of what role they play in helping health centers recruit clinicians. So this is actually data from the Bureau of Health Workforce, which is housed within HRSA and runs the National Health Service Corps program. And this shows that gray bar on the right shows you that 53% of the current National Health Service Corps participants, so participants that are part of this program that places clinicians in underserved areas, 53% of them are actually doing so in a health center setting. And there's a graph that looks just like this that I don't have, but I can tell you that 61% of the current vacancies for National Health Service Corps positions are for caring at a health center. So there's still a bit of a divide between where there's being placements and then where there's still need for those participants. But it's really interesting to see all the different staff types that are pretty dominated by health center specific participants. So 78%, for example, of the dental National Health Service Corps participants are caring for patients at health centers. And then in talking about that kind of grow your own and being part of the training part of clinical care, we asked health centers if they're involved in training for clinical students, residents, or both. And so the majority are involved in some sort of training for clinical and or residents, but we were particularly interested to find out for those who are not currently training residents, why not, what kind of barriers they're experiencing to doing that. And so that's the results here are answers to that question. So for those who said that they weren't currently training residents, the top reason given was that they just don't have that formal relationship with an area medical school or a teaching hospital that can really provide that kind of infrastructure you need to do that kind of program. Other things were more material and logistic. They just don't have the space or the budget. And a lot of them just said they don't really have the kind of knowledge they feel like they need to start that process in that endeavor. So just kind of building off of that, for those who said that they were participating in a residency training program, we asked what institution held the accreditation for that program. And the majority are still held by hospitals and medical schools. But 22%, so 1 in 5 of the health centers who responded, said that they held it themselves, which meant it was an independent project that they were taking on. So I won't read through all of this, but just some of the main takeaways. Again, nearly all health centers are experiencing at least 1 clinical vacancy, and 2 million more patients could be served if those vacancies were filled today. Family physicians are largely the kind of focus and priority for health centers right now, but that's not to overshadow things like behavioral health and other definite needs that they are also experiencing workforce-wise. The challenges they experience with recruitment and retention are largely related to things like competitive salaries, benefits, where they're located, and just the sharp competition they feel from places like hospitals and other practices. But there's definitely evidence that health centers are drawing from the network of other health centers and really using the great run approach, relying on programs like the National Service Corps and other federal programs that place clinicians in the pursuit areas. And many are trying to start doing health professions training, and many already are, and it definitely seems to be a good retention tool as well. That's it. Thank you.
Welcome those who are just joining us. Thank you for joining us today on this very important topic of discussing workforce and announcements. I'd also like to welcome Dr. Robert Wynn. He's with the University of Illinois. My partner, actually my upper line. Thank you, Dr. Wynn, from he's Associate Vice Chancellor for Health for the University of Illinois. Now, what you don't know about Dr. Wynn is he's, I'm going to get this right, Robert. He's the only African American physician who was head of a cancer center in the United States. So that's no small deal. So I want to say congratulations to Dr. Wynn and on behalf of the University of Illinois and on behalf of the health centers. Now, you heard about my many hats and the legacy, but I tell you, Dr. Wynn has also brought a dimension to Miles Square that has been unparalleled. He's so shy. And then you may say, well, Henry, what do you mean by that? Well, his initiative on personalized health, and I think we're going to talk a little bit about that today. Also, because of the kind of person he is and the kind of research interests he has, we now have the opportunity, I think we're one of 2 institutions in the city of Chicago that will have an exchange visit medical program with Cuba. We're physicians from Cuba will visit Miles Square, and where our faculty will visit Cuba to learn how to do medicine and what they've done, because as you know, Cuba has some extraordinary health outcomes. So that could not be done. I'll tell you, my friend, I like to take credit for it, but I can't. Dr. Wynn is in fact credit for that. So thank you very much, Dr. Wynn. In terms of Caitlin's presentation, I want to make sure you heard the challenges not only about healthcare, but you also had a chance to hear about the kinds of patients being served. Patients living in public housing, homeless populations, patients living at or below 200% of the federal poverty level. So when we have a workforce issue, it affects those patients who need it the most. And I'll tell you, as CEO of Mounts Wilson, we're challenged by competing in an environment where salaries have escalated. And the good news is ACA has now provided more care to Americans, great news for that, especially in those states that expanded it. But the downside, and you're going to hear some of that also from Dr. McNeil, in terms of our being able to compete in that environment from a salary perspective. So I'd like to ask Dr. Scott McNeil, who is Vice President and Chief Medical Officer for the Delaware Valley Community Health Center, to also share his thoughts on McNeil.
Good afternoon. First, thank you for allowing us to present on a topic that obviously we're very passionate about, for you to understand the concerns that we have around recruitment and retention issues through our health centers. And I think following a lot with what Caitlin's already talked about, I'm going to try to maybe tell a little more of the story, because we are that stereotypical health center that she's talked about and that data, and give you an idea of what we've been experiencing around this issue for the last number of years. So I only have a few slides, and I'm not going to really read my slides, but rather just kind of talk with you a little bit about what's been happening with our health center. So, this talks a little bit about my health center, Delaware Valley Community Health. I've been the Vice President and Chief Medical Officer there for 23 years. We are located in, most of our centers located in the heart of North Philadelphia. So if you know Philadelphia at all, North Philadelphia is the most impoverished area, has some of the most poor healthcare outcomes in the Philadelphia area. So we have the challenges there. It gives a little statistics about, again, things that Caitlin's already wrapped up in overall statistics for community health centers, but you can see that our patient mix, the providers that we have, mirror some of the things that she just presented to you. But in my story that I could tell is, again, in my 23 years as Chief Medical Officer, I can tell you for the first maybe 15 years or so, I didn't really have a recruitment problem. I didn't have a recruitment problem because I didn't have a retention problem. The kinds of people that came to work for us were those that were very dedicated to work with low-income communities of color. And the only time that I had a position vacancy, the only time that physicians left our health center mostly was for retirement, or perhaps they moved out of the area. So I really enjoyed, maybe even got spoiled with the fact that I didn't really have a lot of turnover. Understanding that it was well documented back then that we were going to be facing a shortage of primary care. That was what people were just talking about. We hadn't really experienced it yet. So knowing that was coming, the other thing that made it very easy for me is that for the last 20 years, I've also been the director of the family medicine residency program. So I have my own pipeline. And whenever I did have vacancies, I could look at and perhaps groom one of my current residents to come along and fill that when it came along. I have currently right now 2 of my former chief residents still working for me. And over the last 23 years, I've had as many as 5 of my former chief residents. Notice I hired the chiefs. I hired the best. I made them chief, I'm going to keep them if I can. So I had my own pipeline, something else that Caitlin was already talking about, how important it is to actually have a residency training program attached to your community health centers. In addition to that, our health centers were known to train medical students, nurse practitioner students, PA students. So we had other pipelines as well. So I felt pretty comfortable, even though that there was going to be a projected shortage of primary care physicians. One thing that I really want to underscore is that when we're talking about hiring practitioners for our low-income communities of color, we're not talking about just hiring anybody. The culturally competent, linguistically competent providers that we need to give to address the needs and give the kind of outcomes that community health centers are known for is extremely important. And so knowing to be a really competent community physician, you've got to know your community. It's quite obvious that a low-income community of color in North Philadelphia and the needs and problems that are there is a lot different than a low-income community of color in rural Mississippi. We've got to make sure that our practitioners are more than just anybody to graduate from the residency program, but have the desire and the knowledge to either already know these communities that they come from and serve, or willing to learn a lot about them. I know for my residents, oftentimes I would make sure that they really were going to understand how to give culturally competent care. They had to go out into the community. You couldn't just prescribe diet when you needed to see what was being sold in the community. It's very easy to just sit there behind the table and say those things, but if most of our patients are getting, their produce from a poppy store, and at the same time that they're buying their produce, they're also got a whole wall of cigarettes advertised in front of them, or malt liquor advertisements right there. Where are they really getting the whole understanding of healthcare? So they needed to understand what the community. If they weren't from this community, they needed to understand what the community they were serving looked like. And I'm really proud to say that we then, and still to some degree now, continue to hire really culturally, linguistically competent providers that want to work in these kinds of settings. So it's more than just looking at the overall availability of family practitioners and internists. It's looking for that subset that's dedicated to that. Now, I don't know how I fell into this, but for many years, including now, I've also been a mentor to many, particularly professionals of color, in terms of helping them navigate through medical school, PA school. And I will tell you why I think that's important in terms of the changes I've seen with them as well. If I go to the next slide, sorry. Again, I'm not going to read from the slides and continue to tell the story that I started, that for the first 15 years I was somewhat spoiled. But I did start seeing in the last 7 or 8 years a lot more turnover, and this coincided with a number of things that happened for our organization. So we had the downturn in the economy. We're a very strong, very well known, both in the city of Philadelphia as well as the state of Pennsylvania, a strong health system. But we too had to take precautions economically. We had freezes on salaries, we had freezes on bonuses. Caitlin's already explained the fact that community health centers already do not pay as well as maybe some private practices and hospitals. So we were already a little bit behind the 8 ball, and we had to put freezes on salaries. That made it difficult. So we had a very rich benefit package. Talked about the National Health Service Corps. For those of you who are familiar with that, this is the funding that allows those students coming out with tremendous loan to work in community health centers and perhaps either qualify for loan repayment, which is very helpful, or perhaps they were scholars, had their medical schools already paid for, and had to do the obligation of serving in the centers for a number of years. So many of our practitioners were on that program as well. So it was a nice carrot for us to be able to recruit and hopefully retain a number of applicants. But as things started getting a little bit of a downturn, we had a problem early on where, I don't know if other people remember this, maybe you do, that the funding prior to President Obama, some of them prior to the ACA, some of the funding, so you fell into that hard category of approved loan payment, but the funds had run out. So approved not funded is not a category anybody likes to be in. That was hurting us in terms of our recruitment retention issues. And then the realization of what we've heard coming in terms of the shortage of primary care was actually happening. And I saw it firsthand. I had difficulties filling my residency classes. Nobody was interested in family medicine anymore. Okay? A lot of it was being driven by a number of things. When I would try to mentor some of the students that I work with, I could see the change. They would come to me as college students, and their dedication, their passion was to work with communities. By the time they graduate, they want to be radiologists. What happened? I don't know. I don't understand. I believe that all of us change our mind when professional schools get exposed to different subspecialties. We certainly are influenced by what happens on television. So ER was real popular. Now everybody wants to be a forensic person, so whatever's happening in the media certainly seems to persuade what people want to do in their professional career. But there's still this passion amongst a number of people to work with primary care. And I always talk about to them that there needs to be a healthy balance between your heart and your brain. But when you're coming out of school with $200,000 and $300,000 in debt, although $150,000, $170,000 salary may be sound nice to the average American, when you're that much in debt and you could make twice that as much as if you were a cardiac thoracic surgeon or more, I think people started choosing subspecialty based on how they could live. So I saw a number of people that I knew were going to be great primary care physicians, only to find out by the time they graduated medical school and chose their residency, were going into other specialties. So I had a difficult time doing my own family medicine residency. So that was a difficult time. So now I didn't have that pipeline. So we got a downturn in the economy, freezing the pay scale, pipelines being shut off, and it was getting a little more difficult for us. And I began to have now both recruitment and retention problems. In the last number of years, the positive things that have happened is you've seen now with knowing that there's shortages coming, there's been more proliferation of more medical schools in this country, class sizes, new medical schools opening, as well as the fact that the physician assistants and nurse practitioners have also become more abundant. And we've had to rely on hiring a lot more of them because they're more readily available. And we've always hired and trained nurse practitioners and PAs, and I think the world of them. But there is a difference as to why physicians train 2 to 3 times longer. And as much as they are a strong workforce, they can't be the only workforce. They still need to be working alongside physicians that may have a little more depth of knowledge to help them along. And we started, just because we needed the bodies and needed to fill positions, we started hiring more nurse practitioners and PAs because they're more readily available. But that's concerning me at times. Many of them were right out of training, and I don't know if they were really ready for the experiences, again, of working with the difficulties, because this can be a high burnout. People are bringing a lot to the table when they come to us in these settings. Yes, they have healthcare problems, but many of them are dictated by the socioeconomic status, the other things that are happening around gun violence and education, and all the things that filter in and impact their health. And I don't know that some of our more recently trained providers were ready for this. So they lasted for 6 months, they lasted for a year and started turning over something again that I had not heard that counted before. So at the same time, good news. The ACA, there's more funding, the National Health Service Corps was propped up a little bit more. You didn't have as many people fall into that category of funded but not approved but not funded. So I was able to have that carrot of baloney payment hanging back out there again. I tried to strengthen my ties with some more of the other residency programs to continue to look, remembering that I'm looking particularly for culturally competent physicians, not just any physicians that come across. So, again, I'm not reading from these slides. These are mirroring kind of what I'm saying in more bullet points. So they're just up there for you to take a look at. But I'd like to continue with just more of a story in terms of what's happening in our health centers. And talking to my colleagues, this is my story is the same for many of them. So where we are today, I still have vacancies right now. I'm still looking for competent family medicine physicians as well as internists. I feel like things are getting better because of the pipeline of more medical schools expanding class. If you look at the residency training, primary care residencies have begun to fill a lot stronger in the last couple of years. Even then filling, some of the graduates still don't necessarily want to work where community health centers are. Even the graduates coming out are still looking to maybe work in suburban practices, in hospital-based practices, where again, salaries are probably a little bit higher. We, after a lot of work by our organization, we just put in place a large salary adjustment for our providers. It wasn't that we didn't want to pay them, we'd love to pay them well what they were worth. I'd like to pay them more than the hospitals pay. But at the end of the day, we are still a business, and we had to make sure that we could find out a way to do this. So our salaries now are better. They're never going to be able to be better than the hospital systems, but I think that they are a little better. The other issue that we see with, and most businesses are talking about the millennial generation, and sometimes that's said negatively. I don't necessarily think it's negative. It's just it's a different generation, and they have different priorities. And we are trying to figure out that same work-life balance that many other corporations, even outside of healthcare, they're asking for different work hours. They don't want to work a traditional 40-hour week. They want to need a little more administrative time. There are a number of things that they are looking for that traditionally, I can say healthcare in general, and particularly amongst community health centers, up until this point weren't used to. So we've had to adjust to the needs of a different generation. And that's been a little challenging for us as well. But we're doing that to be able to track this next workforce. But what I really want to do is continue to try to spread my passion. I'm boarded in family medicine and also in public health. I've been on the board of public health in the city of Philadelphia for both terms of the former mayor, and now I've been reappointed by the current mayor. So, if you look at the needs, look at the outcomes, there's still a lot of work to do. And what I'm talking about in Philadelphia is true of probably anybody who's running any community health center anywhere in this country. So I'm saying this because I see some young faces out here, and I'm hoping that some people out here are also hopefully interested in some way trying to impact and get involved in healthcare in some way. Because we need a lot more people to try to do this. And I think that if we can continue to have pipelines, as Caitlin was talking about, that expose nurse practitioners, PAs, medical students to what goes on in community health centers, I think that they will be inspired, and I think that they will continue to want to try to maybe help us with the mission of the work that we do. Nobody's giving me a time signal. If I start talking about my passion, So I want to make sure I'm cognizant that there are other speakers coming behind me. But again, I think in the slides it talks about some of the things that we need to continue to try to work on. I missed why it's a little more challenging. Electronic health records has made the whole patient visit a lot more difficult in some ways. The economy of having younger clinicians who grew up in this era that can type faster and do whatever, while I'm still also having physicians that are practicing for 20, 30 years who are having a difficult time adapting to some of this. So there's a lot of challenges, and then some of them are retiring early because they don't want to deal with this. They loved it the way it was, and they're retiring because they don't really want to learn how to try to work with electronic health records. So, HRSA funding is something that's still concerning. We talked about the issue of making sure that there's loan repayment. Without going into a lot of detail, that's been cyclical for us. Right now, there's a scoring system. The scoring system worked against us. If you're a community health center in a more urbanized area, and wherever you come from, I'm sure there's gentrifications happening in your area. If you're in New York, if you're from DC, if you're in Philly, you know that there has been a lot of new folks moving into areas, and with that, professional services come along with them. So in our case, if you're doing this by geography, or you're doing this by just counting how many doctors are in a particular area, yeah, there may be a lot of doctors in Philadelphia, but they don't want to take care of our folks. So, we had this scoring system work against us at one point. It was somewhat corrected so that we were having a higher score so we could qualify to have the scholars and loan payment occur. And now there's some new scoring systems that may work against us. Why is that happening? They want to try to have the rural sites have a higher rating to make sure that there are more people being steered to some of the rural areas. And I understand that philosophically, but if you're underserved in Philadelphia and you're underserved in rural Mississippi, you're underserved. And it's very difficult to say that just because there are other providers in the region, if they're not taking care of you, they're not taking care of you. So that's been difficult as well. So I'm going to try to wrap up my comments again. These are some of the strategies that we have done in our health centers to try to combat and fight what's happening around recruitment and retention issues. I feel that we're in a better position than we were maybe 3 or 4 years ago, and I think that again, with resident classes filling a little bit more, but what I really want to do is continue to try to get anybody interested in healthcare to spend more time in a community health center to see what goes on. I have a really good friend, childhood friend, who's a writer in California. I'm thinking about how to try to get him to write a TV show about a physician in a community health center. Maybe that would make us popular, I don't know. But thank you for listening to our concerns, and again, hopefully you can help us with any ideas or suggestions. Thank you.
Thank you, Dr. Actually, pause so that we can hear from our sponsor, and those of us, Congressman Danny Davis.
What I need. I'll tell you what, I'm doing real quick because I'm sort of fascinated by what I'm hearing. As a matter of fact, I was thinking of Curtis Owens that you were talking about Philadelphia. And that's one of the good things when you're my age, because you can remember when health centers were not exactly what they are today. Of all the things that I've been engaged with during my entire life, I would suggest that other than my wife and my family, that the most successful stuff I've been involved with, community health. I got involved with them shortly after they were founded. I used to work at one, Martin Luther King Health Center in Chicago. And I remember 2 guys who were pharmacists there who ultimately one became a dentist, the other one became a physician and was actually president of the National Medical Association during his time, Leonard Wells. And the other one's named Dr. Wells, who practices dentistry out in Oak Park, Illinois now. When I first knew them, they were both pharmacists at Martin Luther King, which meant that when we talk community health centers, we're talking about just cash money. Nothing replaces money. Nothing does what money can do. And so one of the real features is that they brought money to the communities where they were established. Money that otherwise would not have been there. Money. Blues singers say the best things in life are free, but you can give it to the birds and bees. Because I need money. We don't do a lot of politics on the ALC or, it's foundation activity. But let me tell you, Hillary Clinton has proposed that if you elect her president, she's going to put $80 billion into community health centers over a 10-year period. That's $80 billion is a lot of money because there are still communities throughout America that are underserved, don't have the physicians that they need, don't have the facilities that they need. And she recognized, I'm not speaking for her, but I assume that she recognized that even though we've made tremendous progress in communities where programs have been established, and I just don't believe, one, in teaching what you don't know. I get my health center in my community. That's where I go to get my help. I don't believe that you can lead where you don't go. I don't believe you can teach what you don't know. So when I get ready to see the doctor, I go right over to the lounge where Henry Taylor is the chief, and I sit there in the waiting room with the rest of the clients.
Not long.
And the nurse comes, somebody calls me and say, Mr. Davis, you come. First of all, they know who I am. They don't call me Mr. Davis. They don't say number 19. I call that cultural competence. I call that a level of respect. I hate going somewhere and being a number. I go to the health center, I'm a person. I just feel better just being there. Also, I noticed that my good friend, Dr. Rose Green Thomas, is sitting up here on this row. When I first knew Rose, she was a nurse working at a clinic in Gary, Indiana. And people like her are all over America who have advanced, reached levels of engagement and involvement. She's retired, but she actually retired from the University of Illinois as an administrative professor and stuff over there. And she wasn't that when I met her. I know people that I met when they were LPNs, when they were trying to determine what they wanted to be. One woman I know is now the supervisor for the state of Illinois, and she goes around the state deciding whether or not cosmetologists are in compliance. She was an LPN when I met her. But through the release time effort that we had, she was able to go and become an RN. Then she became an MSN. I also remember when we had a great training program where we were training people to become MPHs at the University of Michigan, where Eugene Feingold was a professor who was known as the top of the rock in terms of being a public health professor. We have another program out at the University of California where people get their MHAs, master's degrees in health administration. It was called sit here and listen to all these wonderful things that you're doing. And the last thing I'll say about it, one of the reasons that they are able to do this is because they never forgot policy. Things don't just fall out of the sky. I'm a firm believer in faith, but faith requires a lot of work. And doctors had to learn how to write letters to the editor the same way they wrote prescriptions. If they didn't do nothing but write prescriptions, they wouldn't have the money that it takes to provide service. But since they understood that you got to write letters to the editor, and you got to do some other advocacy things while you're practicing, then they wouldn't be talking about how great they are. They would be talking about how they wish they had what they needed. So, please, it's a pleasure, and thank you all very much. Thank you for being here.
There you can see why Danny Davis is one of them, and the other being Senator Ted Kennedy. So thank you for all the citizens in the United States, and there's 25 million people who are getting here today. I'd like to thank also Dr. Keisha Robinson for joining us today. She's going to join us today to talk now. Dr. Robinson is Director of Medical Education for Unity Healthcare here in the District of Columbia. So thank you very much. And I want to apologize for not standing. I'm not standing because I don't want to upset the slides and kind of clumsy, so don't want to turn things upside down. So I'll stand there. Thank you, Dr. Robinson.
I don't mind myself.
Okay.
I may mess up the slides. Oh, there we go. Thank you. Good afternoon, everyone. Thank you for the introduction. I apologize for being late, but we are a medical school campus and a teaching elsewhere. I just finished meeting with about 30 preceptors of my medical students. So we have an annual meeting that was going along at this time. So I ran straight over from Ward 7 to here because this is very important. So I'm a family medicine physician. I've been with Unity Healthcare, as you stated, right here in Washington, D.C. It says 100,000 voices, one Unity. For the last 4 years, we've been seeing 100,000 patients a year. And so throughout the District of Columbia, we have about 10 health centers, 3 school-based health centers. We also have 2 health services within the Department of Corrections, and also 10 homeless site services, including a mobile outreach van. So with that being said, we have about 1,000 employees and a little under 200 providers. So I say that because being a family medicine doctor, when I was a resident, I needed to return home, which is Washington, D.C., and I was very fortunate to have my residency introduce me to Unity Healthcare. They had a long relationship together, which I didn't know, where our graduates actually went on board with Unity Healthcare, and some are still there. And then I was actually able to rotate there. And when Unity gave me the opportunity to actually practice and serve in the community in which I was born and raised, I was happily able to join that mission and vision. So I've been there for 12 years. Is everyone aware of District of Columbia, the wards that are here? Okay, so Congress Heights and Ward 8, we were there up until 9 years ago, and I was there for 9 years. And then we moved I moved to Parkside, which is in Ward 7. That is our location for our teaching medical school campus. So just like other community health centers, depending on your demand and your need, that community health center will determine whether or not they're becoming an educational health center. And it's all about the collective goal of addressing what the workforce challenges are presenting us. And that is a physician shortage. And are you guys aware of the Association of American Medical Colleges, the report that went out, stating by year 2025, there's going to, and I don't know if you guys mentioned that, but there will be, they gave you a large range, between 46,000 to 90,000 physicians. There's a shortage of physicians nationwide. And when you delve a little deeper into that, because the essence of community health centers is providing primary care and service to our community, so you want to look at how does that affect with what percentage of those physicians are primary care physicians. And they gave a range between 12.5 to 31,000, and that's a shortage nationwide. So who do you think that's going to impact the most? What communities do you think that's going to impact the most? Our most vulnerable communities, and the communities in which community health centers serve. So, Unity Healthcare, we made an investment. And when we were approached by A.T. Stills University, School of Osteopathic Medicine, we jumped on board. And so what we found out is that they had a partnership with the National Association of Community Health Centers, in which they had a plan. Their very first class was in 2007. They had a plan where their students would have their complete didactics on the main campus in Mesa, Arizona, but every last one of those students would go out to a community health center and complete from second through their fourth year and complete their medical school education at a community health center. What does that mean? They're in a class for 90% of the time in the first year, but their initial experience in their second year, they are embedded with precepting teams, continuity primary care precepting teams from second year medical school as a student. And with that being said, it goes along with the whole philosophy. And I don't know if you know the research and the data that proves this. Those who are from the community or trained or educated in the community will ultimately and likely practice in that community or a community similar to that. I'm an example of that research. I didn't know about Unity Healthcare growing up. I didn't, and I'm from Ward 8. But when it was introduced to me, I jumped on board because I am from the community. So in third year, they're still invested. In fourth year, they're invested. So I am happy to say that our first graduating class, as we accepted our first class in 2013, we had our first graduating class this past May. And out of our students at Unity Healthcare, 62.5% went into primary care residencies, which we were very pleased to have. Unfortunately, none of them stayed with our family medicine residency, but that was our first class. Our goal is to hit 30%. So that is to come. In order to do that, we need to go into the communities. We need to go into the high school, the undergraduates, let them know that we are in DC and that we are serving the community that you're from. And research is saying you need to go a little bit sooner than that. You need to go into elementary school, just to know, because they have a sense of my dreams, my ambitions, and we want to make sure that they know that we are present. And this potentially, if you choose, could be an avenue for you. Yeah. So we're very pleased about that. One thing I would have to say before I go on about our teaching health center, and it may have been alluded along the way, some of the challenges that our medical students face, and it's very, very real. And it becomes a highlight when they're third and going into their fourth year. The reason why is because they're trying to decide which residencies to go into. And even if their heart and soul is to go into primary care, I'll backtrack. When I left medical school and my loans were on deferment, and I left residency, I was $183,000 in debt. Our students, and this is probably the middle of the road, we're not the extreme, we're not the lowest, we're not the highest, but our current third, fourth year medical students, when they finish, will be $400,000 to $500,000 in debt. So with that being said, you can imagine what kind of internal struggle that they are having. And we have long conversations. We inform them about the resources. They know that I'm an alumni of National Health Service Corps. I'm a loan repairer. And my best friend is a scholar, and she's OBGYN. So they know about those resources.
Here's the interesting thing about the precision medicine initiative. If we think about it in context from Tuskegee to Henrietta Lacks, and the question, if we think about it in context from Tuskegee to Henrietta, now what, right? The days of we don't want to participate in clinical trials interesting though, because you know what them folks gonna put in you, and we're gonna sit on the sideline and think that nothing's gonna happen. Something's happening. The reality is what's happening is we're not being able to, as a cohort, understand what drugs to develop for us, for African Americans, for Latinos, and for others. Real precise medicine, right? So in that context, there is going to be, I think in November or December, a nation sort of campaign to get us involved in precision medicine. But the crazy thing is, who's having those discussions? Where are those discussions happening? Those types of discussions are what we really are leading in our communities at the FQHC level, as opposed to academics coming in to sort of tell us we should be having those discussions. But, right? The days of we don't want, the crazy thing is, the nice part about this story is that finally for once, we do have 6 FQHCs at the table and hoping to get more because we're starting to get conscious that we just can't do anything but just give out pills in those communities. We have to do even more. That's going to happen. The second thing, and I'll end on this one because this is our precision medicine stuff, which I really absolutely believe in my heart of hearts, that sitting on the sideline just increases disparities for sure because we miss out on drugs. But I think I learned again from my mom, who was the smartest person in my life, and she'll tell you that. But when she said, she used to say, boy, listen, if you are, and I've heard this, and y'all have heard different phrases of this, if you ain't at the table, you own the menu. And so we need to be at the table around clinical trials. We need to be at the table around this precision medicine effort and other efforts that are involving things from the NIH and other things about building cohorts so we better understand. But we need to be at the table to make sure that our community has a voice at these tables while decisions on high levels are being decided for you, as opposed to with us. Now, I am going to stop with this last thing, which is kind of cool, which is why we were a little late. We started thinking about global health, and typically, again, University of Michigan, I went to a medical school, all the rest of the things. So I thought, when I thought about global mission, global health, it's what we know that we take to other countries because, damn it, we're the US. Yeah. But as a young African American, I started looking, and there are other countries that are doing it quite differently. And one of those countries that did it quite differently is Cuba. They have 1/3 of the GDP, and yet they have better health outcomes in the context of their infant welfare and other things. And then you must ask yourself, why? And then the second question becomes, well, if they know something, how come we can't bring it to the United States to help our underserved population? Now, it sounded crazy at the time, but, speaking with Henry and others, and with the support, Congressman Davis, who has been, really a super advocate on helping us out with the Cancer Center and all those these other things in this project, we talked this through and said, you know what, we're going to do it. And in fact, it looked at, with Dr. Chung and others, we were with the ambassadors this afternoon, it looks that it may actually have some legs, and hopefully the Cubans will be coming to the south side of Chicago fairly soon, so that we can learn, not from them, but with them, on how to live a better care. I only say all that to tell you this is where it actually is. They used to say, what's the guy who robbed the bank, they sort of say, well, why do you do it? And he said, well, that's where the money is. Well, interesting enough, I think for decades we all have been where the money is. We now have to get others to recognize that this is where the action is. If you're going to make real impact on population, and you're going to really improve the health of folks in the United States, it's going to be where we are in the FQHC setting. So with that, I will stop. And I will say thank you for allowing me to sort of be here and speak with you, and thank you, Henry, for the opportunity. Appreciate it.
I want to thank all of our panelists today for sharing the experiences at each of their community health centers. And I wanted to say if there was one wish I had and could have accomplished, wish upon a star, is that every community health center has a rock wall. No, I mean that. I mean that sincerely. Wild Square is good. It's a great health center. But I can't imagine, can you imagine what could be accomplished in this country if we had this kind of partnership across the country? When Rob talked about it, he said it, but I don't think people got it, which is the power of, and we had never done this before, data-driven results, the power of going to an alderman's office in the city of Chicago and talking about cancer in their district, in their ward level cancer data had never been done before. Because all politics are local, right? It's about what are you doing from there. So I'll tell you, Rob, it's extraordinary. The idea that we're doing Cuba, it just could not be done without Rob and individuals who are interested in research. I think the comment left by Rob is that we can't be left out, we can't have our communities left off. It's a powerful place in which we can transform medicine. Also, to a call of action, I wanted to sort of make you aware of some key policy issues that we're going to need your assistance with, and they're very fundamental to community health centers. One is that, as you're all aware, community health centers are funded by about $5.1 billion in funding, yet 70% of this funding, the mandatory funding that comes from the ACA, is set to expire by September 30th, 2017. Imagine 25 million Americans getting care today, and we will suffer a 70% cut in funding. It's just not acceptable. Plain and play. Can't survive. It's not fair to our communities. It's not fair to the individual who needs it. How many of you have families who use community health centers? Do you know? Okay. Think about their lives and what can change. So we need Congress to act. Community health centers will serve as the nation's solution to expanding care in America. The other piece that's noteworthy we want to talk about is that today over 10,000 clinicians through the National Health Service Corps provide care in underserved communities. 10,000 clinicians. I want that to resonate with you. Yet, and also of that, 50% or more receive or serve in community health centers like mine. Yet, if Congress does not act by September 30th, 2017, the National Health Service Corps plainly put will cease to exist. I'm going to say it again. Will plainly put cease to exist. Funding will be abolished. John, did I get that right? Thank you. I want you to think about that. Nash, also, you heard from Dr. Robinson about the value of the teaching healthcare organizations. And what they have done is taken providers teaching from the institutions and put them in communities where our families live. Well, less than 1% of the total amount spent annually for graduate medical education. That's a phenomenal savings. That's a phenomenal outcome. So you certainly want the Teaching Health Center program to survive. And today's Teaching Health Center programs support and now train over 700 residents. So that's a major accomplishment. So you've heard today about many of the innovative programs coming from our community health centers, but it's clear that policy issues alone can't address this. That it also requires us to have solutions, create solutions where we live, like Dr. Robinson and Dr. McNeil. So we are ensured that that the resources are there in the community where they're needed. So I want to say thank you. Are there questions from the audience? Yes, I'll pass. Yes, ma'am. You're complete.
And the question is that I'm sharing
I can hear you.
I'm sharing information with young gentlemen, and this is a doctor who has found out, because he was a doctor, that most physicians have been trained to give prescriptions. When he felt that there are holistic products that also can build the immune system and keep them healthier. So I don't understand, if that is the case, why are the doctors not allowed to utilize the holistic approach with 90 vitamins and minerals and those kind of substance? Because I've had multiple injuries from my head all down to my feet and all that. And if I didn't, and I showed these multiple vitamins to my doctor, she said, the best that's going on. But if she knows this, why is she still, or why is she not able to sit at the table with people making decisions and say, we need to do a new approach because it's not working, because once you become a senior and we don't sit at the table and listen to what's going on, and I work with children with special needs and been to a lot of things on the Hill and all this sort of stuff. But if you're not that person and you just have a function in the community and you do what your doctor tells you to do, and you're not getting it. And that's what I want to know. When are they going to start using?
Let me see if one of our physicians on the panel can.
Well, like from Africa or Cuba, where they may not be pushing prescriptions.
Is there a response to any questions about herbal medicine and the use and nutrition environment?
Hi, so I am an osteopathic family medicine physician. There are different trainings. So if your physician is an osteopathic or an allopathic or a holistic, that may require additional education for that physician.
She didn't tell me.
Right.
I was born, she didn't tell me because I sat at the table and I've been a part of this and I've been working with children with special needs, going on the ground and all this stuff. I should not have been bringing it to her. If she's my health care provider, she should have been part of it. And then when I found out that you get these blood tests and all this, and you know you're lacking in vitamin D, and they don't bring it. You know, it's really, I really feel sorry for what's going on in the
Patients should be able to have a sit-down and informed discussion with their patients about their level of knowledge. That has to be disclosed. If doctors are not knowledgeable about a certain area, then they should disclose that and then also refer you on so you can get further education, because it has to be an informed decision. It has to be a joint decision between patient and physician.
But you're not allowed to use
I'm going to ask that we're going to sidebar that. We're going to sidebar that issue. I appreciate that, and we want to give you more information, but we'll have some time for you to visit with one of our physicians after the panel. I think I saw this gentleman has the mic first. Yes,
Hi, good afternoon. My name is David Simpson. I'm a first generation Dominican American. I was born in Brooklyn, New York. I've traveled mostly to the Caribbean, Latin America, but also Africa. I have over 15 years experience in the medical field, working with insurance companies, hospitals, private and public. I have an associate's degree in business administration from the University of the Virgin Islands. I have a bachelor's degree in anthropology from Howard University. And this year I completed my medical degree in La Universidad Central del Este in Dominican Republic.
congratulations.
I fell into the trap of wanting to be an ER doctor because of ER. But during my medical course, during my medical schooling, I got married and I got a child. And I realized that I was more a family medicine doctor than I was an ER doctor. So I came back to DC because I love mambo sauce. I love go-go music. So I'm never going back to go-go. I'm coming here to DC, and I'm going to figure things out here. But because of the way the matching program works, I'm probably not going to get a job until 2018. So my question is twofold. One, could you give me any advice in terms of what job I should be seeking with somebody with my type of experience? Also, what is being done by the healthcare community, the health center care communities, to recruit offshore candidates? There are many students who are not able to get into school, into medical schools in the United States. Well qualified students, and they're making the decision to go offshore to go to medical school. And in all the discussions and all the meetings that I've been to on healthcare, I've never heard anyone bring up the discussion of offshore students. And the only time it came up is when I had a meeting with the president of the National Medical Association yesterday. I had a breakfast with him, and he said that's one of his priorities that he wants to kind of bring to light, to encourage other black men and women to go to medical school and use offshore medical schools as an option. So those are my two questions. One, what are we doing to recruit offshore medical students? And two, any advice that you guys can give me in terms of what types of jobs that I've been looking for? I'm particularly interested in Dr. Robinson's response. Whoever gets me is going to get me for 20 years. I'm not going anywhere.
I'm going to ask Dan to give us an overview in terms of policy. Dan Hawkins, please.
Well, I can tell you a couple of things. One is,
Can we have the mic, please?
Dr. Robinson can verify this. The beauty of the residency program she has, called the Teaching Health Centers Program, it's not subject to the national cap on residents, which currently restrains the ability of any residency training program in America, old or new, to grow the number of residents. Right now, what's the number that are coming out of medical school, medical students who cannot match to a residency? It's in the 10, 15,000 range.
My situation I cannot match. I just need to take my last 2 boards and then get into the
Yeah, well, and the problem is there aren't enough slots. There aren't enough residency slots open, which is why the only thing that's constraining health systems from being able to open up residency slots is money, the cost of doing it. And we're in the process. We are going to try to fix that this year to significantly increase, and thank God for Hillary Clinton, which really means thank God for Danny Davis, because he's the one who influenced her, to put the money in her budget. And when she gets elected, that's not a partisan statement. Except there's only one way, it's her or no. So, I don't want to go to that. But if she gets elected, and we're going to have to fight for it. But a key will be that in those resources that she wants to put in community health centers will be money to grow the Teaching Health Centers program. So there will be residency slots for students, both U.S. educated and educated overseas, to be able to do that. That's something that we are committed to do. And this program, which is the first and only way that new residency positions have been created in the U.S. above the cap since 1997, when Congress put the cap on Medicare, graduate medical education. It hasn't grown one student or one resident since then. This is the only way it's been done, because we're doing it outside of Medicare.
And I think the second half of your question is, what kind of a job should she apply for? Is that what's your second piece?
Well, another shameless plug is that everything that I said in English, I can also say in English.
Some comments on that.
Why can't they open up an office and do what their education allows them to do? I mean, if they have all these qualifications, if they are a doctor and they have these board certified, why can't they move into an office space and do what they've been trained?
Well, being board certified, you have to go through a residency.
Right.
I think if I understand your question,
I think we'll get that answer from Dr. Redfield.
I actually do employ a few internationally trained physicians, and I think that some people may not want to hear this, but passing USMLEs is probably a difficult step for many people. I've mentored many internationally trained physicians that had a difficult time obtaining residency because they had a difficult time passing USMLEs, and I think that's the biggest hurdle for a lot of people. And I don't know if anybody's going to really want to say this publicly, but post 9/11, I think it was somewhat purposeful. There was a lot of scrutiny in terms of looking at international professionals, in terms of them being recruited. Now, the other thing is what Dan Hawkins talked about. My family medicine residency for 20 years that I ran, was more traditionally funded, by CMS, and that cap also created a limit. So prior to that, there was probably a lot more acceptance of internationally trained physicians for residency positions, but the attrition of residency spots, the closing of lots of hospitals, as well as the growth, as I mentioned earlier in my talk about medical schools across the country. So there's now been a preference more, since there is this abundance of U.S. trained physicians, they're preferentially looked at for residency positions over those that are internationally trained. Is there job opportunities? I can tell you right now, for a bilingual competent physician who's passed USMLEs and be able to get through a residency, that I would decide. So I think the opportunities within FQACs are definitely there. It's getting over the hurdles of the USMLEs.
And also I want to mention another component that you may not have been aware of or considered at this point. So right now, our teaching health center is osteopathic residency. So come 2020, when the merger happens in the AOA and the HCGME, there's going to be a merger. Right now, we only accept osteopathic medical student graduates. But come
But there, my residency was only osteopathic as well, but there are, what is being referred to is that it's all going to be under one, but prior to that, there already were combined ACGB, AOA approved programs. So, I don't think that your hurdle is necessarily a residency position. I think that looking at programs like this, that you already targeted what you want to do, I think you need to look at resident programs. Again, USLME may be some of the hurdles in the past as well.
And the
Yes, Congressman.
reason there's a cap is because there are people who want there to be a cap. See, the one thing that we sometimes don't always remember is that everything is political. There's no such thing as a cap it just does not happen. There are people who believe that we have enough physicians. They don't want to increase the number of physicians. They come to people like me and try and show me the reason that we don't need that let's keep it as it is. And so generally thinks one way about it. Somebody thinks another way about it. And I always say the difference between politics and government is what you got. Politics is what you want.
Rick Blake, Strategic Health Resources. I didn't want to let Dr. Wynn's really brilliant remarks connected biomedical research and federally qualified health centers go just flat like that. And I wanted to congratulate Congressman Davis, because in 2010 we worked with his office. We have a bill. I'm trying to tell you, we have a bill doing that connection, and I can dust it out of my computer, and I am certainly willing to work again. Caleb Gilchrist was the staffer that I worked with in Congressman Davis's office. I would be more than happy to renovate that bill, make it more current, but Congressman Davis had the foresight to support that bill in 2010, and I would be more than happy to work with you to work on that bill again, and hopefully in 2017 that maybe get advanced. Okay? Yeah.
Yes, ma'am. Your name?
My name is Norma Baker. I'm from Springfield, Massachusetts, and I'm wondering how much nutrition education physicians get. I was diagnosed with rheumatoid arthritis 3 years ago, and I was sent for every test you could think about, including physical therapy, only to go back to my doctor and have him do a blood test and find that my vitamin D level was low. He gave me mega doses of vitamin D for about 6 weeks, and all the symptoms of rheumatoid arthritis disappeared and have never come back. How many people are on drugs for illnesses that can be cured with the vitamin? And especially seniors, because as we get older, our body is depleted of certain vitamins. If you don't have vitamin B12, you could be losing your balance and running into walls and thinking you're having a stroke when you just need a vitamin B12 shot and continue to do it. So my concern is we talk about drugs, and my position about that is the pharmaceutical companies have no incentive to cure you. They deal with repeat business. So there's no incentive for them to cure you. when there are natural things that we can take, that our grandparents have taken, that basically can stop a lot of the illness, especially in the African American community. I had a friend whose knees were so bad that they were going to operate on them. And I suggested to her that since you can't get up anyway while you're sitting down, rub those knees in some coconut oil in the morning and at night. The next time I saw her, she was out of the. So there's simple things that the pharmaceutical companies know about, they can't make money off, but it's really not only not helping people, it's killing people in our community because we don't get that kind of information. And we get on drugs that cause you more problems than the problem you went to get solved.
I certainly can't speak for the entire healthcare community, but this is one of the reasons why I personally and love FQHCs and why other of us are so inspired to work with FQHCs, because it is a true team-based approach. Smaller private practices may be just a physician, and that's all you get to see. One of the reasons why FQHCs get funded differently and get their visits paid for differently is because we have a team of professionals. It's not uncommon to find a physician working with a nutritionist, working with a social worker, working with an HIV/AIDS specialist, working with so many other people in a team category, using lay people from the public. If you look at FQHCs in Hawaii, they have physicians and lay dealers working side by side. We embrace, what was often talked earlier about holistic, we embrace the teams, but I can't say that happens everywhere. But I can tell you it happens a lot within FQHCs. So when you ask about our training for nutrition, we get a lot of training as physicians for nutritionists, but I know my limitations. That's why I'm a nutritionist. So if I know that there may be more information that needs to occur, it doesn't have to come from me. I don't have to be the welcome all the information. I've got a team of people that work with me. So that's my response for FQHCs.
I think, I wanted to make one quick comment too, that, people are really bashing sometimes, and I think rightfully so, some of the things that are happening in healthcare. But I want to remind us in 1950, when the doctor actually, in this case, saw the Dwight D. Eisenhower, who actually was having a massive heart attack at the time. There was only two things to do. That was put him in a quiet room and not have anybody visit him, which was the standard of therapy, or maybe give him the new drug called aspirin. If Dwight D. Eisenhower or any president right now comes into my ER with crushing chest pain, we not only have multiple ways of sort of figuring out where it is, but I have now a decision to say, do I give this guy thrombolytics? Do I cath him? And then once I actually get him back, which of the myriad of drugs do I actually put him on to personalize him? So it is true that one could make the argument, and it's happening in our community, that we're also dying from not getting, for example, EGFR mutation called Tarceva. There's a drug we know called Tarceva, which interesting enough is epithelial growth factors, that actually interesting enough came from 30 years ago when some crazy guy was actually doing at the Bank, which is why I love big science, the fruit fly. Now his understanding of the fruit fly led to this concept of growth factors and epithelial growth factors, which led to other things, which we now can, in a miracle way, as was written in the New York Times and other things, and you can look through the literature, actually says, if we know that you have a specific mutation, that can be targeted. We have data now that says that person doesn't live 6 months, 5 months, but they're living up to years past what they used to, because again, the advent of medical therapy. So while there's certainly an argument about using alternatives, which I am absolutely all about, I am down with alternatives as long as you can prove to me that they work. Now the reality is sometimes what people tell me is like, yeah, I just read something on my arm, and then I say, well, all right, now if you put that on 1,000 people with the same thing, who gets better? And if only 1 out of 1,000 gets better, then we have to ask ourselves, is that real too? Now there are definitely things that I believe we should do, but I also believe that we should have data and evidence for it so that we can roll it out to more people. And so my attitude is, it is time where I think we should be community scientists in the way that actually in Cuba we'll know. They'll know if actually rubbing something from a plant on 1,000 patients that's feed by one family doctor is working or not, and that gets reported back to center. How often does that happen in the United States? So the reality is information remains power, and while I can definitely dog out pharmaceutical companies, because I will every single time, because it's about the money there most of the time. But the truth of the matter is we cannot forget that there are drugs that actually work and save lives, aspirin being one of them. People think aspirin was around all the time. It wasn't. So we have to keep a balance, right, of what things like the vitamin D. Honestly, this is why I go to team-based, because we're now asking our docs to do things that if you had a doc in the 50s, 60s, 70s, 80s, and even 90s, we're asked to do, which is keep up with almost everything. And so it is even more important now that the community be involved and we actually surround that physician with a team.
I am not bashing doctors.
Oh, no.
But I also want to be clear, I am bashing pharmaceutical companies. Have something you never had before.
Well, I just want to make a comment. I concur with my colleagues. Please, anyone who has a primary care physician, there needs to be a team. There needs to be a nurse. There needs to be an educator. Physicians cannot do it on their own. There's a mentality out there that the physician ends with the physician. It should not be there. There should be a team circling the patient, and each member of that team is doing a function. Now, we actually have a pharmacist join our team because that pharmacist is actually helping out polypharmacy, making sure that physician is not overprescribing and make sure there's no contraindication. So in essence, there are functions behind different specialties and we work together and serve the patient. So I agree definitely with the team.
This is an exciting time. Community, and this is what's more is needed, community and science and medicine come together. But I can only do one more question, ma'am, and you were first, and come on down.
Thank you. My name is Priscilla Chapman. I'm the president and CEO of Chapman LLC, and we happen to be the Washington representative for Rush University Medical Center, one of your partners there. And we likewise are here because of Congressman Davis, and we thank him for everything he's done for Rush University Medical Center. But actually my question is wearing my other hat. I'm also the federal designated navigator entity for the state of Delaware. Under SOCIO, CMS, we are the navigator program for President Obama's Affordable Care Act. And we are the grassroots, boots on the ground, who are going out educating and enrolling people into the Affordable Care Act. So we work with community health centers, the federally designated ones in Delaware, as well as we had Maryland doing open enrollment 1. But my question is about, you all talked a lot about partners, and it was actually relevant to some of the pieces we've talked about with other programs, and cultural competency. That's really a very, very key word for us. And so I know the funding challenges of federally qualified health centers, and one of the things now, CMS is really recognizing social determinants of healthcare and talking about transportation. It really relates to precision medicine as well. And so a couple of things we know the literature about. I'm an attorney, not a doctor, but health policy has been my expertise for 25 years. And what we know is that, number one, when you were talking, Dr. Wynn, about clinical trials, there are people called patient navigators whom we employ. And when patient navigators are used to talk to minorities about clinical trials, first of all, recognizing that Tuskegee is a reality and things have changed, but how you make that change. When we use patient navigators, you get a large participation of African Americans in clinical trials, but we know that probably FQHCs don't have funding to employ, firms like ours.
We have navigators.
Oh,
yes,
okay. Fantastic. And the second thing we work on is knowing out in the community, a separate piece is persons who have diseases like diabetes and high blood pressure who have not been diagnosed or either are diagnosed but are non-compliant. So we work in that space as well, because that's, again, cultural competency. How do you get people in to be diagnosed, and then how do you get the medication compliant? So, we work in that space knowing that's a big part of that cultural competency. And I think, one of the third things that's really important about that is just both a lot of things like immunizations, all of that community health worker type people, whether you call them community health workers or navigators. But so I did have a question, which was, do community health centers actually have funding to utilize those services, as some of the wealthier centers like a Rush has funding for that?
Dan, you were talking. You answered the question about the ambulance services.
I think it's great that places like Russia and navigated programs are working with health centers. You know, just recently, HHS reported that health centers were responsible, this is health centers across the country, for 1 out of every 3 people who enrolled in Obamacare. That's pretty doggone good for one group. And working with navigator programs like you, that boosts it even more, makes it even greater. That's important because we have the new enrollment period starting up on November 1st. And there are still way too many people out there who need health care. They think it's unaffordable to them. They don't understand the fact that not only is there a subsidy for purchasing the premium of health insurance, but there is a subsidy for the cost sharing, the deductible, and the copays, especially for people below 150% of poverty or 200%, like the majority of health center patients. So it can be very affordable for them, but we've got to get the word out into the community, okay, and tell people to sign up. That's going to be important so that they have access to care.
I'm going to close with just Congressman Davis naturally, but also we have a gentleman from NIH like to have him. You put a few remarks, please, if you don't mind. National Institutes for Health.
Hi everyone, I'm David Chung from the National Cancer Institute of the National Institutes of Health. Real quickly, I know Congressman Danny Davis doesn't remember me, meets a million people, but I met him in 1997 with Barack Obama right before he was president at the Juneteenth event with Ronald Myers. So even the people that you don't remember, you have an impact on. I only became this position today because of that moment, probably. Huh? Also, my wife is a graduate of AT still. She's an osteopathic, and so I too am at that 400 to 500 range. That's why I work so hard these days. But the point is that I know I was with Broadway today at the Cuba Embassy, and so we have some exciting news, but more importantly with the FQHCs as well as other things, we're working together to figure out ways to partner up with cancer centers and FQHCs to help build infrastructure and create more jobs, especially with underrepresented populations. And so hopefully next year, the NCI as well as NIH will have a little bit more of a formal partnership to maybe perhaps attend and be a bigger part of this and show a lot of the great things we're doing, especially with a lot of opportunities that we hope to create for the future generation of workforce. So thank you so much for having me today.
Can I in connection with Dan Hawkins, who's from the National Association? Can the National Association staff please stand so they can be recognized as the best association staff on the planet? So thank you very much.
Well, all I really want to do is, first of all, thank Henry for his facilitation of this discussion. As usual, he did an outstanding job. Thank you. Henry and I have been together in the last few weeks, though. We were at a church banquet a few Saturday nights ago, where the pastor and his wife were renewing their 25th year vows. Then, of course, Saturday, just this past week, we were at a street festival in the Inglewood community at something called the Jericho Walk. And they were giving him an award. And so congratulations for that. I want to thank all of our panelists. As I said somewhere this morning earlier, my daddy used to tell us that a little knowledge is a very dangerous thing. He said you had to drink deep, because shallow drinking intoxicates the brain. And as we had the discussion, foreign medical graduates, I just happened to have been in Cuba at the opening of the have folks registering to become physicians. And the interesting thing about it is if their countries didn't have any money to pay for it, Castro was paying for it, Cuba was paying for it themselves. And they were training physicians for South America, for the Caribbean, and there were even a few from the United States. The last time I was there, we actually had a meeting with several medical students from the United States and from Chicago who were engaged and involved. And I guess much of what a country does actually has to do with the will and the decision. Serving on the Ways and Means Committee, we talk a great deal about money, what it is that we're willing to pay for. And I know that my good friend Charlie Rango is retiring, but at the time that we passed the Affordable Care Act, Charlie was the chairman of the Ways and Means Committee. And anybody from New York who might be here, you need to just let Charlie Rango know that Danny Davis is a great fan of his, because Charlie led that bill through the Ways and Means Committee. The three committees that really had jurisdiction in the House was Ways and Means, Energy and Commerce, and Education. But the major, quite frankly, was the Ways and Means Committee. And Charlie shepherded that legislation through. I'm excited because my sickle cell bill just had a hearing in Energy and Commerce the other day, and I understand that they're going to mark it up. And of course, once we mark up a bill in the committee, that means it's coming to the floor, and they're going to, in all likelihood, pass it. I think we can. When I introduced that bill and it got it passed, it actually set up 17 new sickle cell treatment centers around the country, and also provided for Medicaid to pay for some non-medically related activity that was a part of treatment for people with sickle cell. So anytime you have a bill that gets passed, I mean, we talked about one this morning in child welfare that we actually got passed and is waiting for the Senate to take it up. But if you get a bill passed, as much activity as there is relative to anything in this country that is national in scope, when you're not talking about a community, you're not talking about a neighborhood, you're not talking about a state, you're talking about the entire United States of America, which is a major undertaking. And so those who know the legislative process know that everything is regulated. I'm saying there's nothing, so anything that you think is irrelevant, don't believe it. There is somebody that's got an interest in everything that goes on, no matter how minor it might seem to be. To someone else, it is major. I want that prescription for that rheumatoid arthritis. I'm going to give that to my doctor. See if he can understand it. But it's really been just a number of years. I want to just say hi to the distinguished judge, Judge Burnett, who has been so engaged in the whole issue of substance use and abuse for any number of years, and whose son, I'm talking high school, actually involved in the creation of Viagra. Sure was. All right. So, for those of you who didn't know, you actually experienced history. And I'm certain that his father has been very proud of him, and he had every reason to be. But that's the other thing about this public business. You get an opportunity to interact with so many interesting and outstanding people. You get a chance to learn things that you didn't know. That's why I try to sit through as many discussions as I can, to listen, so that when we're debating CMS rules and the poor hospitals, the safety net, are saying, do you expect us to have the same outcomes as some other institution? That I can say, well, if you discharge a person to the alley because they're homeless, and they have to get readmitted, should the institution be penalized for that? And I can know what I'm talking about because I know something about people being homeless, or people not having a place to live. So readmissions for them probably won't be the same. I used to be a member of the board at Miles Square, fellow, Mr. Binkley, who was an attorney. And he used to ask the medical director, and he talked real funny. He says, doctor says, let me ask you a question. Suppose you treat a poor boy who ain't never been to the doctor and never had a steak. And you prescribe some medication for the same guy who's a millionaire, has been having health care all of his life. Would you expect him to react the same way? I mean, those were some of the icons that, for example, the father of Earth, Wind, and Fire, Dr. Bernine Adams, used to be my podiatrist when he was at Mount Square. And I'd go in and get him to look at my feet, and he'd want to talk about Bernine, Maurice White, what concert they've done, all that kind of stuff. And I'm saying, doctor, I got all these. Let me tell you, you meet some of the most interesting people. I mean, through the health centers, we've met people who became assistant secretaries of health and human services, who was in charge of bureaus, who went to public health agencies. Clifton Cole, who was the first president of NAC, became the deputy director of the public health department for the state of California. Yeah, Cliff went and became that. We know individuals who've done just have the rest done. And we didn't turn the water to wine, but you know, we find that a little bit is good for some things. That's what some of the faith people have told us down through the years. So please join us and share a little bit of libation as we culminate the evening. Again, thank you